You know, when we hear the term eating disorder, our brains usually jump straight to a very specific image, right? It's an image that's been heavily shaped by the media and decades of cultural conversation. But what if I told you there is a severe, life-threatening eating disorder that has absolutely nothing to do with body image? Well, today in this explainer, we're going to explore a condition that literally hides in plain sight. It's so often mistakenly brushed off as just extreme, picky eating, but the reality? It's a highly complex neurological and psychological puzzle.
Think about it for a second. We almost always assume that all eating disorders are driven by a singular obsessive desire for thinness. But is that actually true? For the longest time, the clinical world focused almost exclusively on conditions defined by a deliberate drive for weight loss. But as our understanding of brain chemistry, sensory processing, and human behavior has evolved, we've had to radically expand our definition of what it actually means to have a disordered relationship with food. We basically have to separate the physical act of starvation from the psychological motive of wanting to be thin.
And there's a massive difference between the myth and the reality here. While conditions like anorexia nervosa are deeply rooted in body shape distortion and an intense fear of gaining weight, ARFID, which stands for Avoidant/Restrictive Food Intake Disorder, is completely different. It represents a severe feeding disturbance that is entirely unrelated to weight concerns. It's exactly that absence of body image distortion that makes ARFID so incredibly unique and, unfortunately, historically so difficult for parents and medical professionals to actually pinpoint.
So, here is our roadmap for today. 1. The hidden eating disorder. 2. Diagnosing ARFID. 3. The 3 drivers of avoidance. 4. Signs and severe symptoms. And 5. Pathways to treatment. Let's jump right in.
Starting with Section 1. The hidden eating disorder. Breaking the stereotype. For a really long time, children or adults who refused to eat out of fear or sensory discomfort kind of just fell through the cracks of medical diagnoses. They didn't fit the classic mold. But, clinically speaking, the contrast is night and day. Anorexia features marked body image concerns, whereas ARFD sufferers exhibit absolutely none. Furthermore, people with ARFD rarely engage in traditional purging behaviors, like self-induced vomiting or excessive exercise to burn calories. Their restriction is entirely disconnected from the mirror. Moving on to Section 2. Diagnosing ARFID, the DSM-5-TR criteria. Getting ARFID officially added to the DSM was a literal game changer because it validated the suffering of thousands of people who were left without a clear medical pathway. The medical definition establishes it as a recognized, distinct disorder focused entirely on a persistent failure to meet energy or nutritional needs. Listen, this isn't just a kid who prefers chicken nuggets over broccoli. This is a profound eating or feeding disturbance, where a person's diet is so limited that their body is physically failing to sustain itself. And again, it's driven by reasons completely unrelated to body weight. To actually get an official diagnosis under Criterion A of the DSM, patients have to exhibit at least one of these severe consequences. We're talking about significant weight loss, or if it's a child, a real faltering of their expected growth. We're looking at significant nutritional deficiencies, a dependence on oral supplements or even a feeding tube, and a marked interference with psychosocial functioning. Imagine being so unable to eat that you can't even attend school, go to a friend's house, or sit down for a family meal. It's clear evidence that ARFID goes far, far beyond typical picky eating.
And then there's Criterion C, which is honestly the ultimate key. It's the primary feature that distinguishes an ARFID diagnosis from anorexia or bulimia. To confidently diagnose ARFID, clinicians must definitively rule out that the avoidance is happening during the course of anorexia or bulimia and confirm there is zero disturbance in how the patient experiences their body weight or shape. That is the hard medical dividing line.
Which brings us to Section 3. 3 drivers of avoidance, the culprits.
If it isn't about being thin, we really have to ask, what on earth is interrupting a human's fundamental survival instinct to eat? Well, there are 3 distinct clinical drivers at play here, and they can definitely overlap. First up is sensory-based avoidance. This is an intense sensitivity to the appearance, color, smell, texture, or even the temperature of food, often described as food neophobia. Second, a fear of aversive consequences. This is usually a conditioned negative response. Imagine a child who experiences a really traumatic choking event, right? They become terrified that eating will cause it to happen all over again. And third, simply a severe lack of interest in eating or a chronically low appetite. For them, eating feels like a chore, not a biological drive.
Let's dig into Section 4, Signs and Severe Symptoms, the Medical Reality. While ARFID typically emerges in early childhood, usually around an average age of 11, it can occur across all ages and weight spectrums. And this is a super important point from the DSM. Despite lacking body image concerns, the body stars in exactly the same way. ARFID can lead to life-threatening malnutrition. Patients suffer from delayed puberty, vitamin deficiencies, weakened bones, electrolyte imbalances, and severe cardiac complications like bradycardia, which is an abnormally slow heart rate. The physical presentation is practically identical to the medical severity of severe anorexia.
And to put this into perspective, there is a staggering statistic we need to talk about. ARFID doesn't just exist in a vacuum. It has a massive 13.7 odds ratio with autism spectrum disorder. That means someone with autism is almost 14 times more likely to develop ARFID, largely because of those overlapping sensory sensitivities. It also has a huge 4.1 odds ratio with anxiety disorders. This tells us for sure that ARFID is deeply intertwined with neurodivergence and the nervous system.
All right, our final piece of the puzzle, Section 5, Pathways to Treatment, a Multidisciplinary Approach.
Now that we know what it is and what drives it, how do medical professionals actually treat it? Well, you kind of have to throw out the old playbook because the underlying psychology is completely different from classic eating disorders. And since ARFID is a relatively recent official diagnosis, it's vital to note that there are 0 FDA-approved medications for it. None. When medication is used, it's purely off-label to target comorbid conditions. So doctors might prescribe anti-anxiety medications or use drugs like cyproheptadine to help stimulate appetite, but there's no magic pill that just cures sensory sensitivities or the traumatic fear of choking.
Instead, the leading evidence-based approaches focus heavily on a multidisciplinary strategy. The absolute first step, just like with anorexia, is medical stabilization and nutritional refeeding. Patients with ARFID actually often require enteral nutrition, meaning a feeding tube, and sometimes even longer hospital stays than anorexia patients. Once they are medically stable, the leading psychological treatment is CBT-ARF. This is an exposure-based cognitive behavioral therapy tailored to the patient's specific driver, whether that's sensory exposure or trauma processing. Family-based treatments are also highly effective, especially for adolescents, to make sure that nutritional rehabilitation keeps going strong at home.
Doctors rely heavily on pediatric growth charts. Tracking those height and weight trajectories is really our absolute best proxy for assessing if a developing brain is getting the nutrition it needs. As we see in clinical cases all the time, a child can completely fall off their growth curve in a matter of months. Catching that drop early, before the physical stunting becomes permanent, and before the anxiety becomes completely entrenched, is exactly how clinicians can step in and manage those acute physical risks.
So, I want to leave you with this thought. For literally generations, we've told people struggling with food to just eat it, or we've assumed they were just being stubborn or obsessing over their waistlines. But when we finally separate the physical act of eating from our societal obsession with body image, we open the door to genuine empathy. Recognizing ARFID as a valid neurobiological condition allows us to drop the judgment and focus on life-saving treatments. So the next time you hear someone dismissed as just a picky eater, maybe ask yourself, is it a preference or is it a hidden medical battle? Thank you so much for joining me on this explainer. Keep learning, keep questioning, and I'll catch you next time.